Thank you very much. I'd like to thank the organizers for the opportunity to be the token surgeon here today, although I did notice there was one person who's at least one other surgeon in the room. We're going to change focus a little bit. A lot of the previous talks have focused on Crohn's disease. This is specifically about ulcerative colitis and about the challenges that we face in the operating room when we're treating these patients. And it's also a change in focus from what I think most of you would consider minimally invasive disease to what most of you would consider maximally invasive disease, or maximally invasive therapy, which is surgery.
I think just hit it above it.
There we go. I actually, unlike Sandy, I can see over the podium, so there's no excuse for me not being able to change the slides. I have no conflicts. So there are a couple of basically three different things I wanted to address that affect us as surgeons when we're taking care of pediatric ulcerative colitis patients. And the first really has to do with the diagnosis. And we know, and the studies are conflicting about the increase in incidence of inflammatory bowel disease, but at least anecdotally, I would say that we are seeing more and more younger and sicker patients who present for surgical therapy. And so that has a significant impact on our decision-making regarding the diagnosis itself, as well as the timing of surgery, and raises the question about what about outcomes in patients who have surgery at such a young age. Similarly, in smaller patients, there are technical considerations that we have to think about when we go to the operating room for doing a pull-through for ulcerative colitis. It has to do with the number of stages in which the operation is done, the use of laparoscopic approaches, and procedure modifications from the standard operation that's done in an adult when you're talking about the difference between an 80-kilo man and a 15-kilo child. First, we all know the surgical approaches for ulcerative colitis certainly started as the classic three-stage approach, in which first there's an abdominal colectomy with an ileostomy, followed by a completion proctectomy with an ileoanal pouch and a diverting ileostomy, followed by an ileostomy closure. In patients in whom we're able to obtain reasonable outpatient control, that can be reduced to 2 stages, which significantly decreases the morbidity for the patient by reducing an entire hospital stay. And in that approach, the colectomy is done in conjunction with the pouch creation, whatever type of pouch you use, and a diverting ileostomy, followed subsequently by an ileostomy closure. More frequently, people have been interested in the approach of a single-stage operation. And as usual, this was much more commonly employed in the adults and is now being more commonly employed in children. And I'll give you a little bit of data based on that. The surgical indications, as we know, are different in children. We hardly ever, I think I've had 2 patients where we actually talked about dysplasia. We virtually never talk about dysplasia or cancer. It's always refractory disease, complications of the medical management with things like growth failure or risks of medical therapy. But there are surgical concerns, and some of those concerns have to do with the intraoperative complications, the disease evolution, long-term complications, and I'll discuss one in particular that I think is particularly concerning that we don't always focus on as much as perhaps we should. And then what are the long-term outcomes? And in terms of the difference between pediatric patients and adult patients, there's a reasonable amount of literature. We actually were very interested in examining the difference between the very young patients and the older pediatric patients. And as I said, we really feel like we've been seeing a lot more younger, sicker patients lately. This is data from a study that we've just completed, and I'm not going to present it in detail because 2 days ago it was accepted for presentation at the American Pediatric Surgical Association in May, but since I doubt most of you will be there, I'll at least give you a brief overview. We wanted to look at, as I said, the outcomes differences between very young patients, that is less than 11 years of age and greater than 11 years of age. And suffice to say, without going through all the specific data, there was essentially no difference in the complication rates for the patients, and the clinical outcomes were virtually identical. That is, bowel movements reduced from 12 to 14 bowel movements per day to 5 per day following the pull-through procedure. The limitation is that's with follow-up of only about 14 months. So again, we still have the concern about progression of disease or the patients who ultimately turn out not to do well, and we're concerned about them actually having Crohn's disease. We also did a quality of life, looked at quality of life, and there was also no significant difference in that measure as well. As far as the pull-through procedure goes, most places now do some form of a laparoscopic procedure, and laparoscopy can have lots of different definitions when it comes to bowel operations. They can be completely laparoscopic, they can be laparoscopically assisted, or they can be open. I'll demonstrate for you or show you the approach that I use and is used by many, but basically it involves a laparoscopic colectomy with creation of the J pouch, which is usually the pouch used in an extracorporeal fashion, followed by either a stapled or a hand-sewn anastomosis. And so the technical considerations for us really have to do with how is the pouch made and how is it brought down and secured to the anus. And then whether or not, as I mentioned before, we should use a protecting ileostomy. This demonstrates the laparoscopic approach. You can see the trocar sites there, and it's always amazing. It's always the sort of rabbit out of the hat thing in the operating room when you have spent a couple of hours dissecting out the colon, and then you bring it all out through the little right lower quadrant incision, where if doing a protecting ileostomy, that's where we would do the ileostomy. The laparoscopic approach provides excellent exposure down deep into the pelvis. And in the little video there in the right upper corner, you can see dissecting out the rectal pouch using a harmonic scalpel, but really it allows you to see very clearly deep into the pelvis much more easily actually than you can do that with an open approach. Many people mobilize the colon laparoscopically and then do a fan and steel type operation to do the pelvic part, but in children and from my perspective, the pelvic part is where you benefit the most from the laparoscopic approach. In doing a classic 3-stage operation, which we do, you end up with end ileostomy, as you see in the lower picture on the right, with the trocar sites that are shown. So clearly, it's something that teenagers like because of the cosmetic impact of it. In terms of the pouch construction, pouches are obviously designed to decrease stool frequency and to act as a reservoir. However, I have significant concerns that if the pouch is too large, and the way I was taught that if it extends up out of the pelvis, it won't empty well, and that will increase the risk of pouchitis from stasis. We know that pouches over time increase about 30% in volume over the first year or so if you do contrast studies. So we worry about making a pouch that's large, or even if it's just the appropriate size, that over time it will increase. The patient will have poor emptying and be at risk for pouchitis. So we have to modify the pouch construction based on the size of the pediatric patient. There are a number of different pouch constructions. There are S pouches and J pouches and K pouches and W pouches and all that. I was actually taught to do the S pouch, but a J pouch is by far the easiest to technically construct, especially when you're doing it laparoscopically. So I would say the majority of people doing this in pediatrics use a J pouch now, although that certainly has not always been the case. The J pouch that you see in the diagram there is 15 to 20 centimeters in length, and that's the typical adult size of a J pouch. When doing children, I'll modify the size of that pouch, rarely make one over 12 centimeters, and we'll go down to 5 to 7 centimeters in a child who's less than 5 or 6 years of age. The pouch, again, this is the laparoscopic view, and that's a picture of the pouch being pulled down through after a mucosectomy for a hand-sewn rectal anastomosis, or anal anastomosis, excuse me. You can see on the side there is the mesentery, and that's the part that's tight. And that's the thing that's hard in this operation, is to get the pouch down far enough so that you can sew it so that it's not under tension, that the blood supply to the pouch is adequate, and that you don't get a leak from that anastomosis just above the columns. So, as I said, I was taught to do an S pouch, and that pouch was done with a hand-sewn technique, but in most adult cases, or many adult places, they do what's called a double staple technique, and that is that you staple off the rectum deep in the pelvis, and then use an EEA stapler to create the anastomosis to the pouch. The challenge with that in a child is that most of the commercial staplers will not fit deep enough into the pelvis to divide the bowel in the deep pelvis. And so a modified technique that we've adopted, and a number of other places have as well, is to actually dissect well down in alongside the rectum, deep into the pelvis, to the level of the sphincters, evert the colon, and you can divide it then at the level of the columns, which is where we would start our mucosectomy anyway. I had one of my partners who doubted that this was possible, and so for the first several patients, he would actually scope them first and put a stitch at the top of the columns where he would start his mucosectomy, and then would do the eversion, and you can clearly see, you get right out to the stitch, you can divide the bowel in exactly the same place. So I think it's a great advantage. We did not develop the technique, but I think it's a great technique because it really allows you to do the stapled anastomosis, which makes it much easier to get the anastomosis done without tension. Because once you put that little rectal cuff back inside and pull the pouch down, there's much less tension involved, and you don't have to see it to sew it. You can simply use an EEA stapler to create the anastomosis. The anastomosis, as I said, is at the same place I would do it with an open technique or a mucosectomy, which is right at the tops of the columns. People are concerned about the amount of tissue that's left there and the risk for dysplasia and potentially malignant degeneration. But as I said, the positioning is the same. And in addition, there have been studies of mucosectomy that have shown up to a 7% incidence of retained mucosal islands that will still be at risk for developing in dysplasia or malignant disease. So the staple technique is significantly easier, and I think it works very, very well. So I am a big proponent of laparoscopy. I was very fortunate to work with Dr. Baldessano at CHOP, and relatively early in my career, and I was a big laparoscopic surgeon, and this was a great population to develop laparoscopic techniques, and remain a big advocate of laparoscopic surgery. The question is it really better? And there was a Cochrane analysis done in the Netherlands in 2009 in which they reviewed 11 trials, included 607 patients. 41% there were 253 patients who underwent a laparoscopic approach, which is 41%. However, as with many surgical things, and I'll admit that up front here, there was only one prospective randomized trial. And the outcome of that analysis was that there is no significant difference between the laparoscopic approach and the open approach. The differences were things like the operating room time is longer, and from doing these, I can always tell the next day because my back is killing me. It takes about 90 minutes longer for the minimally invasive approach. As I showed in the slides before, the cosmesis score is definitely better, so patients like it, especially teenage patients and their parents actually appreciate the fact that they have minimal scarring. But there was no difference in mortality, morbidity, reoperation, or readmission. So what about the complication rates? This table shows you the difference in the complications. Minor complications, 28 to 30% in the laparoscopic group and 23 to 27%, so essentially identical in the open group. Just a point on that is that this is not a small operation and it comes with a significant complication rate. So a quarter of the patients to a third of the patients are going to have some sort of complication. Fortunately, severe complications are relatively rare. Intraoperative complications are even rarer, and mortality is almost non-existent. But overall, a 38 to 40% complication rate for this extensive procedure. In terms of outcome, this is a list of the studies that reported outcome, and you can see the laparoscopic procedures on the left and the adjacent to the open procedures, with daytime bowel movements in the 5 to 6 range and nighttime bowel movements of 1 to 2, exactly as you would expect, and equal between the two groups. And what about the need for protecting ileostomy? As I said, in a number of adult centers, ileostomies are rarely performed these days. That's not usually the case in pediatric centers. I think we tend to take more of a selective approach. There was a study published by Dan Duty in 2011 in which they looked at 83 patients with ulcerative colitis and 7 with familial adenomatous polyposis. 68% of those patients had no ostomy. 56 patients were done as a single stage. 12 were done in sort of the reverse of the two-stage procedure where they had a colectomy for an acute disease followed by a pull-through without a protecting ileostomy. 19 had a traditional two-stage operation. There were only 2 pelvic complications. Remarkably, there were 19 pouch revisions, and I was really shocked at that. And when you look at it, the vast majority of the pouch revisions occurred in patients who had an S-pouch construction. And typically the problem with that is the little snout at the end of the S-pouch is too long and the pouch doesn't empty well. But without the S-pouch issue, then there's, I think, a reasonable rate of success with a single-stage operation. So I personally have moved more towards using a single-stage approach, although in many of the pediatric patients, as we said, they come in very sick, and we do a total colectomy first, just to get them out of the hospital and get them better, and may follow that with a second operation without a protecting ileostomy. Finally, just to mention long-term complications, we all know about the issues of incontinence and pouchitis. I've already discussed the technical aspects of pouchitis that I think are important in terms of how the operation is performed. Bowel obstructions are common, but I think less common with the minimally invasive approach. And the one thing I'd like to just spend an extra minute on is the issue of infertility. This is something that we discuss with all of our patients before they go to the operating room. And I have great hope that a laparoscopic approach will have a positive impact on that, although it is not a trivial problem. And this is data from a systematic review of the literature that was recently published. And this compares, there were only 6 studies in which patients were compared for fertility pre-pull-through and post-pull-through. And the average is it goes from a 20% infertility rate to a 63% infertility rate. So that's really a dramatic increase and something that I was surprised to see numbers that high. 80% of patients, that's thought to be due to trauma or scarring of the fallopian tube when studied with contrast studies of the tube. So this is a very important problem that I think we bring up but maybe don't emphasize enough. I was presenting once in Europe, and a surgeon stood up and told me that if he ever did a pull-through on a patient in a pediatric age group, he would be thrown out of his hospital for this reason. So there are people who take this quite seriously. I think it's something that deserves more study as we have more experience with the laparoscopic approach. So in conclusion, I'd say that smaller patients require technical modifications of the operative technique, that the laparoscopic approach to ulcerative colitis provides a cosmetic benefit, but it's pretty hard to show that to demonstrate any other benefit in terms of outcome. And finally, that long-term studies to assess complications of recurrence of adhesive bowel obstruction and fertility may help to demonstrate a greater benefit from the laparoscopic approach. Thank you.